Hi, everybody. Welcome to the March meeting of the Free Inquiry Group. We are dedicated to improving the human condition through rational inquiry and creative thinking, unfettered by superstition, religion, or any form of dogma. We welcome this evening an excellent program, something I've been interested in for many, many years. I'm sure most of you have too, which is the single payer universal healthcare system that most civilized countries in the world have. So we are still striving towards that end. And we're happy to have our speakers here today. And I'm going to turn it over to Peter, who's going to give you a little bit of information about the program. Let me just say that we do have a website. If you're interested in membership and you're not currently a member or you need to re-up your membership, you can do that by going to gofigure.org. We welcome your participation. And with that, I'm going to turn it over to Peter.
All right. Thank you, Kat. We have Dr. Jeanne Corwin with us, and she's going to discuss the state of healthcare in the U.S., including she's going to talk about the number of uninsured, the number of underinsured, the number of deaths due to lack of insurance, and so on, and much more. Dee Chavez, RN, that's not Republican nominee, that's a registered nurse, will introduce SPAN Ohio, its goals, and how its members are trying to achieve them. She will also review health value dashboard, the health value dashboard, and we have a link to that. I will send out a report about this this event. It'll also be on our website recorded, so you can watch it again or tell your friends to see it, and you will be able to go to Health Value Dashboard, SPAN Ohio, and these places you're going to hear everybody talk about. If you have questions during the presentation, go ahead and enter them in chat, and I'll try to wrangle those questions, and when it's time for our Q&A in about an hour, 45 minutes, an hour, whatever, I'll try to get the best of those questions put forward. I'm sorry, your questions will be filtered down by my judgment. So with that, I don't know which one of you wants to start first, Jeanne or Dee, but Jeanne, go ahead, you're on, and folks, you should be able to see on your other Zoom channel her PowerPoint or whatever it is you're using. Thank you, you're on.
Okay, well, thank you for having me. Dee and I have given a number of talks together, and just a brief background about who I am. I'm a long-term Cincinnatian. I went to Miami University a million years ago. Then I joined the Peace Corps. I lived in the Central African Republic for 2 years, came back and did medical school and residency training here at University of Cincinnati in obstetrics and gynecology. I've been with the same long-term practice for all of my 25 years. I just left recently, and I'm working now part-time at a women's clinic in Dayton, Ohio, but I still live in Cincinnati. I'm again a longtime Cincinnatian, and I live in Pleasant Ridge. The group that both Dee and I belong to, and you'll see it at the bottom of the PowerPoint, is Physicians for a National Health Program. It's been around. It's embarrassingly long time that it's been around and working towards a universal single payer healthcare. But the goal of the group is to advocate for universal healthcare on a national level. So I'd like to go ahead and start by going through a few definitions and talking about the state of healthcare in the United States, because I think we have to understand what we've got to understand why we need change. Here's a very long definition of universal healthcare by the World Health Organization. I think we can skip that and just say universal healthcare means everybody has healthcare from birth to death. It's that simple. So single payer, a lot of people, go, what the hell does that mean? So it's where you have one entity who's paying or financing healthcare. And what we're advocating for is, of course, the government to be the single payer in our healthcare. We have that as an example in the United States with our Medicare system for traditional Medicare. people pay into it, Medicare pays all the bills. So that is sort of an example of a single payer healthcare system. Canada to the north, of course, is our best and shining example that we have close by. A few other definitions. That big socialized medicine you see now on the screen. There is nothing wrong with socialized medicine. A good example, of course, it would be Great Britain, and they do an excellent job with their healthcare system, and it is a socialized medicine system. But what it means is that the government not only finances healthcare, but it also employs all the doctors and all the employees, and it owns the hospitals and the equipment. So really that the government owns and operates the entire system. Closer to home, our example of that would be the VA hospital system would be an example of socialized medicine, as well as our Indian health system. Again, nothing wrong with socialized medicine, but it is, it's a trigger word, shall we say. Also, just briefly, Medicare is financed by the government. Medicaid is a combination of financing through the federal government and through the states, and it is for people who qualify are low income. So those are just some brief definitions to make sure we are all on the same page. So let's start by talking about the uninsured problem in the United States. So it is currently estimated, the most recent estimates I could come up with for 2019, it's estimated that approximately 13 to 14% of people in the United States have no insurance. That translates to about 30 million people. The lowest point of uninsurance was in 2017. We had only 10% or 28 million uninsured, so it's gone up in the last few years. We can go back just a few years prior to that. Prior to the Affordable Care Act, 18% of people in the United States had no insurance. That translates to approximately 42 million people. Keep in mind that all of these are estimates. We can never really know how many people in the United States are without insurance. I'd like to, just briefly give maybe an example or two about a patient having been in practice for 1 million years without insurance. But keep in mind, I'm coming from a gynecology practice where we don't see the worst of the uninsured because most of our patients who are uninsured simply don't come. We are not the front line like in an emergency department or even a primary care physician who probably see much worse examples of people who just don't have insurance. For a gynecologist, we usually see people who don't show up. Now, we do get glimmers of the uninsured because we have people who we know who disappear and come back, or we'll see people as new patients who haven't seen a gynecologist in a number of years. And so I will bring up just one patient because it really just, was, I thought, a good example. She was a woman in her mid-40s. She was brand new to me. So in taking her general health history, it came about that she's an insulin requiring diabetic, and she volunteered that she was back. She had a whole list of things she was getting taken care of for her health. And I was kind of towards the end of her list, but she had been without health insurance for approximately 5 years and had recently, obtained health insurance. I'm not sure what avenue she took to get the insurance. But in taking her history, it came out that she has in her mid-40s diabetic retinopathy, so vision loss from her longstanding diabetes, and also some neuropathy or long-term nerve damage from her diabetes. But you may wonder, well, how did she survive without insulin? Of course, she hasn't. She would pay cash to the pharmacist. The pharmacist ethically cannot withhold insulin to anybody who needs it because it's life-saving. They don't even have to have a prescription. She had been paying cash for her insulin, but she had been uncontrolled and unmonitored for about 5 years. And at a relatively young age has long-term irreversible complications for her diabetes. So I thought, well, this shouldn't have happened. She shouldn't have had those serious health changes at such a young age. And it was all due to her lack of health insurance and her inability to seek regular routine care. So that's just one example I'd like to share with you. Uninsurance also causes people to die. Again, it's estimated, but it's estimated that we have about 28,000 people who die every year in the United States, wealthiest country in the world, due to a lack of health insurance. Now let's talk briefly about underinsurance, because this is huge as well. What does underinsurance mean? Quite simply, it means you can't afford your responsible cost of the insurance that you have. So you have insurance, but you can't afford it. Meaning your out of pocket expenses might exceed greater than 10% of your income, or your deductible exceeds greater than 5% of your income. It's estimated, as you can see on the slide, it's a little busy, but about 20 to 40% of people are underinsured in the United States. So if we combine the number of uninsured with the number of uninsured, we're talking almost half of the population of the United States either has no insurance or can't afford the costs that are related to the insurance that we have. So this is not just a problem of people of financial who are in a poverty level or slightly above that. This is a solidly middle-class problem that affects almost the majority of people in the United States in one way or another. So it's a huge problem. I'd like to give you a patient example that directly relates to underinsurance. So again, I'm in my gynecology practice and I've seen a woman. I'm looking through her chart, I guess electronically, before I saw her, looking back, and I saw she had been seen about a year ago. She's in her early 60s. And I saw that she had called a few months before saying that she was having some bleeding. Now, I'm a gynecologist, so you can imagine where she was having bleeding. I won't go into any of the details of that, but she called having bleeding. So we had made an appointment for her to come in. And then I saw that she had canceled the appointment. She had called and canceled. And now here we were several months later, and she was just coming in. So I walked in and we were talking. And I thought, my gosh, I wonder if the bleeding had stopped, but even still, that's still a problem. It needed to be looked into at her age. And I said, I noticed you called and then you canceled. Are you still having this bleeding problem? And she said, oh yes, I've been bleeding pretty much every day, maybe a little off and on since I called a few months ago. It wasn't heavy. And I said, can I ask you, was there a reason why you didn't come in to see me a few months ago? And she said, because if I came in a few months ago, it would have been considered a problem visit and it would have gone towards my deductible and I would have had to pay the full price. Where by waiting these few months, she had reached her yearly annual visit date and she knew that her annual visit would be covered at no cost to her. This is what insurance does to people. Now, this is a woman who works full time, pays taxes as a citizen, and has private health insurance. But that's what these costs do to people. It's just shocking. Yes, it took us just 2 or 3 days to diagnose her with uterine cancer and referred her on to appropriate specialty care. So I think that is just a shocking example. And I'm not going to go on and on and on, but I could go on and on and on about all the ways the underinsurance affects people. Every day it would come up. Is this going to be paid for? How much is it going to cost? I can't afford that. But, for time's sake, I will leave it at that one example because I found it just so jarring in so many ways. So that's what our system does to people. We also know that underinsurance reveals itself in the form of personal bankruptcies. 62% of personal bankruptcies, people report that medical bills was the leading cause of their bankruptcy. As you can see by this slide, of the people who went through bankruptcy, 3/4 of them had insurance at the time. So again, underinsurance, people can't afford their deductibles, co-pays of the insurance that they have. Unfortunately, the percentage of bankruptcies, unfortunately, did not decrease with the Affordable Care Act. So how do we justify our system from a social justice standpoint? And I get it that not everybody cares about social justice. I personally do. Not everybody does, but I think most people care somewhat for the common good. Our system cannot be defended from a common good or social justice standpoint. A lot of people at this point will kind of think, well, I know we've got a lot of people and we don't have insurance, or, they can't really afford their medical bills, but it's just so daggone expensive. We can't afford to cover, we in the United States, we can't afford to cover everybody. It's kind of the mindset. So let's move on to the next segment. Well, how much are we paying in the United States for health insurance? This is a shocking slide. So if we compare our healthcare costs in the United States to other economically similar countries, you will see that we're spending, it's about $10,000 per person in the United States now every year. So if you compare it to other countries, it's about half of that. So we're spending in the United States twice as much as economically similar countries. And yet we have all these people who don't have insurance or can't afford the insurance we have. It's estimated that the United States is spending 17 to 20% of our GDP on healthcare, and the actual annual budget, it's $3.5 trillion. That's how much we're spending. Okay, but if you break it down to per person, you can really see how we differ from the other countries. So why do we spend so much money? And I know everybody thinks, oh, because it's for profit. It's a for-profit system. And yes, it is a for-profit system. And that is one of the reasons, but that's actually not the main reason why we're spending all this money. We're spending all this money because our system is so complex with all these different contracts, all these different insurances. You re-enroll, you de-enroll, you have to see who's on your plan, who's in network, who's out of network. A hospital system has how many different contracts with each different insurer, and those contracts change, every year or so, they have to renegotiate a contract. So I'm gonna make this up. For example, maybe Anthem has perhaps maybe 15 or 20 different contracts with each different healthcare system. This is incredibly complex, and it leads to a 30% overhead. So 30% of our healthcare dollars are paying just for the administrative costs to run this beast. It's incredibly complex. Traditional Medicare has an overhead cost of 3%. 3%. So it's the complexity of our system that drives up most of this cost. And of course, it is also because it is a for-profit system. That certainly does increase the cost overall as well. There's our insurance overhead. Again, economically similar countries are spending about half of their healthcare dollars for administrative costs that we do. Now, here's the profits. It is a little disconcerting when you look at the pharmaceuticals and the health insurance companies are the leaders, not a surprise, since they are our leading opposition to changing the system that we have. So here we have a system. We can't justify it from a common good standpoint. We can't justify it from an economic system. You don't have to care about people and humanity at all. But economically, we can't justify what we've got going on. We still have some people who are holdouts. They may say, well, I'm really sorry about, people who don't have insurance, and it's really a shame we're spending so daggone much money, but But I don't want to change the system because we have the best healthcare outcomes in the world. People really believe that, you know. So this one, we really don't need to spend much time on. We all know that our healthcare outcomes in the United States are appalling and an embarrassment. We can take many different factors that you can look at and compare them. But if you want to look at the overall best reflection of how a healthcare system functions, you can look at life expectancy. Now, this slide is actually from 2016. In the last 4 years, even pre-COVID, the life expectancy in the United States has decreased every year, which is really unusual because usually when the economy is going well, life expectancy goes up. Now I'm talking pre-COVID, but pre-COVID, the economy was flourishing and our life expectancy continued to drop every year. So, okay, so what are we left with? How do we justify the system? We can't justify it from a common good. We can't justify it from an economic, and we cannot justify our system from health quality, from health outcomes. We can't justify it. There's no way to justify the system unless you work for the pharmaceutical company or for the health insurance companies, and that's no justification. So what we're proposing is, excuse me, let me just take a sip. To overcome this is a universal single payer system. And the biggest proposals, there is a bill in the Senate and there is a bill in the House of Representatives, and they mimic most closely the system that is in Canada. So it's actually not a socialized system. It's a system where it is financed by the federal government, but it is not necessarily run by the federal government. You can still have your private practice, you can still be hospital employed, but the government doesn't employ everybody. The government doesn't own all the buildings and all the equipment, but the government is in charge of financing. So of course it would be universal. If we look here, comprehensive, we would care for more than we do currently. There are so many holes in our system. No co-pays, no deductibles. You would not be allowed to have a for-profit system, no marketing, no advertising, improved healthcare planning, especially for prevention, for rural areas that can be healthcare deserts. And of course, if everybody's in the system, there's public accountability. We're all in the system together. There is some power in that. So the Physicians for a National Healthcare Program, along with many other agencies, are advocating on a national level for a universal single-payer healthcare system. Big question, people still say, well, how do we pay for it? Well, this is very busy, so you don't really have to study it. But if we go back to all that money we're spending on administrative costs, if we can bring down our administrative costs, if we can cut them in half, which is in line with other countries, and you can only do that through a single payer system, you've got to get rid of the complexity of the system. That automatically is going to free up about $500 billion. I said billion, not million. About $500 billion that would go to healthcare and not for administrative costs. So then what this slide shows is a number of different studies that have been looked at if the United States goes to the universal healthcare system. And as you can see, the savings are the green. And if you look at increase in cost utilization, because we're going to be covering more people and more services, that's the red, and the savings is the green, and then the blue line goes down and overall savings. So most studies show an overall, we would spend less money overall than we currently are. So overall, oh, part of the slide didn't come through. It makes economic sense. Basically, what it was supposed to show is that 20 out of 22 studies have shown overall we'd be spending less money than we are now. Keep in mind, we have a $3.5 trillion budget. Oh, there it is. Sorry. I'm not very advanced technologically. And there are many things that we could talk about, but because of time, I would like to stop here. We do have bills in the House and the Senate. And again, I will mention that the biggest opposition to any movement on this front has been the lobbies for the pharmaceutical companies, the health insurance companies, and somewhat the hospital organizations. And they are incredibly powerful. And we have had very little movement in overcoming their powerful lobby. And I will turn the talk over now to Dee Chavez, who we work together, and we're in the same groups, but she's going to talk more about Ohio. And there is movement nationally for a universal single payer healthcare system to start in one of the states. If we can't get it to start nationally, the thought is perhaps to get it started in one of the states, and it can go from there. So I will turn it over to Dee Chavez, and she'll take it from there. And I will stop my screen sharing. So there.
Okay, thank you. Jeanne and I are also both members of a group called SPAN Ohio, which stands for Single Payer Action Network. It's a statewide group. There are approximately 18 states that have their own single payer organization, whatever the name is. It can be a different name. And the thought is that if we could get a bill passed in a state or two, it would be easier to do it that way, because then it would be like the states are, let's see, some famous Supreme Court Justice Louis Brandeis said the states are the laboratories of democracy. And lots of other things have happened that way in our history. Things like, now I'm drawing a blank, but a lot of things, a lot of labor laws, a lot of environment laws, and the
marriage equality.
Right, marriage equality recently.
Started in the States.
Women's suffrage, very important one. So in Ohio, this group has been in an organization for 19 years. It's a grassroots organization. We do have several thousand people on our database, and lots of other followers on Facebook and Twitter. The goal is to bring about a new system in the state of Ohio that would be a universal, publicly funded system of financing for healthcare. Again, as Jeannie said, it's not socialized medicine, it's socialized funding of medicine. And I'll talk about the funding in a little bit. But first, I want to talk about the state of healthcare in Ohio. The Health Policy Institute of Ohio has been putting out what they call a health value dashboard every 2 to 3 years. And the last one came out in 2019, and it's in April of 2019, and they're just about to put out a new one in April of this year. I'm anxious to see that, but I don't know the statistics on that yet, but I'm gonna go back to the 2019 dashboard. So what it does is it ranks performance in healthcare. It's called health value, which is a composite measure of health outcomes and spending in the state. Our overall ranking in Ohio is 46th out of 50 states in the District of Columbia. So we're in the bottom quartile. Now it's a very comprehensive report. It's such interesting reading. To me, it is. I'm going to give you just some individual statistics, just are going to give you an idea of how we rank with other states. In drug overdose deaths, opioid overdose deaths, we are 50th. it probably comes as no surprise. We're 50th out of 50 states in the District of Columbia. Only West Virginia has more overdose deaths than we do. Now that may have changed. I've heard that actually overdose deaths have increased, but I don't know if that's true in Ohio. But because this is from 2019. In infant mortality, our ranking was 44th. In premature death of any kind, our ranking is 43rd. In life expectancy, Ohio ranked 42nd. Poor oral health, 42nd. Adult smoking, 44th. And some of the conditions, obesity, we ranked 41st. In cardiovascular disease mortality, we ranked 39th. That means strokes and heart attacks, basically. So we're not looking so good in Ohio. It's pretty stark here. Now this report, and I really would encourage you, if you're interested, in this subject, to go. You can. I think Peter said he was going to put that link on the chat, but you can actually just go to the Health Policy Institute of Ohio, and they have abundant information, and they do have that full report, which is about a 30-page report, 25 to 30-page report. And they list also some of the social determinants of healthcare. I'm just going to give you a few of those. So family and social factors. There's a thing called ACE, which means adverse childhood events, which refers most basically to different types of child abuse, neglect. And we know from studies that if you've experienced childhood neglect or abuse, you're much more likely to have poor health in adulthood. We are in the third quartile, which, out of the 4 quartiles of the 50 states, or 51 plus the District of Columbia, we're in the third quartile on ACEs, child poverty, preschool enrollment, high school graduation. And some of the other social factors that we're in the 4th quartile are adult incarceration and adult unemployment. And there are several other things like homelessness, housing, and so on that contribute to poor health as an adult. As a child and as an adult. So why does Ohio rank so poorly? It's a complicated question, a complicated answer, but basically there are just too many Ohioans that are left behind. Ohioans in rural areas, particularly, and also minorities. Let's see. In healthcare spending, I'm going to go over that a little bit from the report. We're actually in the top percentile for employee spending, which means, the portion that your employer pays for your health insurance. But we're in the bottom quartile for these things: nursing home care spending, hospital care spending, and total Medicare spending per beneficiary. They do have some equity profiles in the report, and not surprisingly, many of these rankings are lower for Black and other people of color in Ohio. And I just want to give you a result of a study that was done on how being on Medicare when you reach the age of 65 affects your health. they have, from the standpoint of racial diversity, people over 65, if you get to that age and you get on Medicare, you're likely to do just as well in your health as if you're Black or a person of color as a Caucasian person. So there's a much better survival rate among all the races. Okay, now COVID has only worsened this situation. As we all know, it has certainly pointed out the problem with racial disparities in our healthcare system. And it points to the need to address healthcare access in Ohio. All right, so now I want to tell you that SPAN has worked with our state legislators for many years. In the beginning of SPAN, we helped craft a bill. And I won't go into the details too much about the bill. It's been introduced in every House since 2004, and in almost every Senate, in every General Assembly. Let's see. There are several Democratic legislators that have pushed this forward. I'm going to go into the politics just a little bit, that have been very, very helpful about pushing this issue forward. And I just want to tell you that Representative Mike Skindell has been there from the beginning. He's a representative from Cuyahoga County. We have a couple representatives here in Hamilton County that have been very, very supportive as well. Catherine Ingram and Cedric Denson, if you know those names. We are just about to have, Mike Skindell, the rep from Cuyahoga County, is about to introduce the bill in the House. We're just now working with him on getting as many co-sponsors as we can. Now, in 2018, SPAN commissioned an economist, Dr. Gerald Friedman of University of Massachusetts Amherst, to perform a comprehensive study of the financing of a single-payer system in Ohio, using the Ohio healthcare bill that was in place at that time. So here are the advantages over the current healthcare system that we have. First of all, Jeanne mentioned about the huge administrative costs of our current system. Our bill would reduce, according to the financial study that was done, the economic study, would reduce administrative costs from 9% to 2% of healthcare costs. And that would save $9.3 billion per year. It would increase disposable income for 95% of Ohioans. And the largest group that would benefit would be the working and middle income families. Now, businesses would benefit greatly too, because they would not have to pay the premiums, their portion of premiums that they pay. They would pay a tax as all individuals would pay. So the money for the system would come from individual income tax, tax on income, I'm sorry, and then business taxes. But it would be much lower than it is for currently for the premiums and copays and deductibles that people currently have. As I said, for 95% of people, it would be a great savings. The tax would be a 3 to 5% tax on individuals, and it would be a progressive tax. And if you get to the income of over 200,000, there would be an added tax. For businesses, especially small businesses, would be something about like a 10 to 12% tax. And I've talked to some business people, and they've said that would really be much easier, much better for them. The other things, I think Jeannie mentioned this, it would reduce the barriers to care, which often always are the financial barriers, the co-pays, and the deductibles. 33% of Americans have that problem, and 1.3 million Ohioans. It would eliminate medical bankruptcies. Ohio has 20,000 bankruptcies a year that are caused by medical costs, and that would be eliminated. And it would reduce economic inequities among the working class and among people of color. So in this economic study that was done, it was estimated that we would have a total of $38 billion savings. We would request from the federal government approximately $75 billion that we already get as a state from Medicare and Medicaid. We would need an additional $40 billion from taxes, and that would be easy to do with the figures that I just gave you. Businesses would probably be able to hire more because they'd have lower expenses. And we think that it would attract businesses to Ohio. So the question is whether Ohio can afford to keep paying for an inefficient and wasteful system, or whether we can afford not to change the system in Ohio. So the bill that's coming out soon is called the Ohio Healthcare Act. Now, what we do as a group is we do lobby all the representatives and senators that we can. Of course, go out and educate and inform the public as much as possible, and raise money as much as possible. We have a website, spanohio.org, if you're interested in looking at that, and you can look at some of the teleconferences that we've had in the past year or two. Some very interesting speakers. Wendell Potter, for example, who was a past CEO of Aetna Insurance. He was with that company for something like 18 years. And he tells a story that a case came across his desk of a young girl, I think 14 years old or 15 years old, who needed a liver transplant. And the insurance company, the people who make the decisions, had denied to fund that. And he looked at that and he said, wait a minute, we've got to be able to figure out how to do this. And I don't know what all he did, but he somehow said this has got to change, and got it changed. And this girl had died before they were able to, make the change so that she would have been able to get the liver transplant. And that was his deciding moment. He said, nope, I'm not going to do this anymore. He left Aetna, and then he helped form a group called Business for Medicare for All. Anyway, he has a very interesting talk on our website. I would encourage all of you to watch that. And there are several other good speakers there. You can also look up this economic study if you want to go into the weeds with it. It's a 60-something page document. It's very detailed and very interesting. I think that's about all I have to say, and happy to take questions now, both Jeannie and I.
Okay, I guess, well, Kat, I guess you're the boss here, but I'm kind of running the machine. Oh no, I'm the host. That's right. I've been made the host. So first, thank you so much for educating us and bringing us up to speed. In the chat, I've put some links, but everybody on our mailing list will get a report about this event, and I'll have the links in there. If you're not on our list, go to Go Figure. It's like Go Figure, but spelled figure, gofigure.org, and just say subscribe and put me on your list, and you will get this report. You will get the report on this thing, and it will have all the links. And I'm going to ask Dee and Jeanne to give me some more. If anything I missed, I'll give your website, and all these important events um, will be in a document you can link and click and learn more about this. This is very educational. It's stunning. It is just, it's shocking in many ways. When you said Ohio was 50th, I thought, oh, great, that's wonderful. But no, that means the bottom, not the top. Um, let's see here. Questions that have come in. Now I need glasses. We can open it up to like wild questioning too, if you want to just bump in. But Michelle asked, how long before we think that we might get progress on single payer public option? Who can answer that? Dee or Jeanne? Jeanne, you're muted. Oh, no, you're not anymore.
Well, so the public option is just like a Medicare or Medicaid buy-in. Keep in mind, if we buy in a public option for Medicaid, it's estimated to be $8,000 a year. So not that it's not good to have more choice, but it doesn't solve the problem. We're still going to have the uninsured. We're still going to have the underinsured. We're still going to have these huge administrative costs. So it just actually increases the complexity of the system to add another option. I'm not against that as an option at all, but it's just, we're just picking at the edges of this problem without really solving it. And let's keep in mind, we're the only economically advanced country who does not have a universal healthcare system. We lag so far behind. We are not creating the wheel here. People have already done it, and we just refuse.
As I mentioned earlier, we, USA, think ourselves so wonderful. We're way behind in women's rights and suffrage and end of slavery and so on. So, I once asked in 1975 when we were talking about metric system, I asked a carpenter, "Hey, aren't you glad we're going to go metric? Because it's a better system, right? Simpler." And he says, "No, we're bigger. They can use our system." And so there's still that, and it's not invented here, and we're not going to go for it until we feel. It's very frustrating. I ask my question here. I'm a Kentuckian, and I look at Ohio's stats, and I guess your stat website might tell me more, but I guess we're doing worse, aren't we? Can you answer that, Dee?
It doesn't give the statistics for other states.
Okay.
Except a few of some of the worst states, which aren't too many. So I can't really answer that about Kentucky.
Okay.
I'm sure they have some sort of an organization, but I can tell you they do have an organization that's working on single payer in Kentucky. Kentucky Single Payer, I think it's called, and it's just started a few years ago. So I don't know how strong it is.
Okay, so I'm ready to. I don't have any more questions in the queue unless I missed them. So you got a little raise your hand icon you can use in the reactions section of your thing, or you can just raise your hand or speak up, and y'all can ask questions. We say y'all in Kentucky. It means everybody is the. Yes, go ahead, Brian.
Oh, okay.
Brian Corwin.
Typed a question kind of towards the end of Dee's talk, and I wasn't sure.
We can't hear it.
Kevin, you're a little low on your volume. Can you fix that?
Can you guys hear me okay?
How's that, Giovanni?
Better.
Better. Okay, go, Brian.
Lean in a little bit. So, for the Ohio Healthcare Act, would that provide coverage that's similar to what Medicare covers currently?
Yes, it's very similar to the national plan that Jeanne was talking about. It's actually improved and expanded Medicare, so it would cover dental, vision, of course, hopefully better mental health coverage, rehab, and that those things. So it would, and of course, be expanded to everybody. So yeah, it would be similar to Medicare for all, Medicare.
But let's keep in mind that Medicare for all is a misnomer that we're kind of stuck with, and it's not a terrible misnomer, but the system that's being proposed is not taking the exact same Medicare system we have and expanding it. It's similar, but it's improved Medicare for all. So it's not the same.
Okay. Okay. Who else had their hand up for questions?
I did, Michelle.
Go, Michelle.
Okay, so I don't think any of us here have a problem with this. I mean, we all want it, the single payer, but how likely are we to see it and when?
Predict the future, Jeanne.
It just seems like the big money is going the other way.
Absolutely. You're absolutely right, Michelle.
Oh, and it's blocked it since before we were talking earlier, the 1960s. It was, we got Medicare and Medicaid, but it was supposed to be a universal system, but it was blocked by the same organizations that block it today. They have very, very deep pockets. So healthcare is not political, but you know, the only way we're going to change the system is through political channels. And there's only one party that will have any interest in doing this. And we as a people have to be more vocal and demand it. And it has to become more accepted as a concept, which it is. Every year, the percent of the population that supports a universal single payer system goes up. It's well over 50%. And so we need to work with the political channels that we have, and we are all aware of some of the inherent problems in our representation, shall I say. Mm-hmm. So I can't predict. There's so much, but it might be a while. But ultimately, it's going to have to come from the citizen. We as citizens are going to have to demand this. I mean, we all know someone, if not ourselves personally, we all know multiple people have been affected negatively by the system in one way or another.
Yep. Yeah, I had a doctor intervene for me on a simple request that was, the doctor knew what was going on, and the healthcare insurance company said, no, we don't do that. And he had to interview and say, yes, we do that. And it wasn't life-threatening like the story you told, but it was, doctors should make those decisions. Brett?
Oh, yeah, this is Randy.
Randy, I'm sorry.
I'm using Brett's machine now.
Gotcha, my mistake.
He's in the background.
Sorry.
First of all, thank you, both speakers for the information. We appreciated it, the insight. My question is, in Ohio, we, as any Ohioan knows, we have quite a rigged state legislature because our districts are so gerrymandered. So, and the party that is considering this kind of plan really has no political power in the state house or in the governor's mansion. That other party, though, I think, is there any way that they might be swayed by some sort of, is there like a business group or a business association that has kind of seen the light regarding this and could put pressure on them? Or is there, is the hope that, we really need to go to a state where there's a little less, I mean, where there's more democratic support?
Well,
because frankly, I don't see that happening in Ohio.
It's definitely an uphill climb in Ohio, because you're right, we're very gerrymandered.
Cliff.
We do talk to the Republicans, and some of them are actually fairly interested. They don't want to commit to it because they think they'll lose their next election. I think they might be surprised, because when we go out and talk to people in the community, lots of people think that this is a good idea. Mm-hmm.
If I can,
we see ourselves as educators for that
if
part.
I can, on the political level.
Hey, Giovanni. Giovanni.
Am I on, Peter?
Giovanni. Dirk and Karen have the next question. I'll get you after them. Okay.
Okay.
Good. Thank you.
Okay, this is
Just
Dirk
say
and
one
Karen.
more thing.
Let Dee and Jeanne finish, please.
One more thing about you asked about other states. Yes, there are probably other states that are more likely to do it. California, of course, is much more progressive, and I think they have a good shot at it. New York has an organization. They might have a good shot. I don't really know what's going on there right now.
Jeanne.
Yeah, quick comment also about that. The business, that's a real push with the PNHP, Physicians for a National Health Program, is to develop the business interests that support the cause, to educate and develop it. So that's kind of the future of the organization, because you're exactly right.
Dirk and Karen. Dirk, you have a question, or Karen?
Yeah, how does this Ohio bill dovetail with the Medicare?
Would it replace it?
Or is it an option if you're over 65?
It would replace Medicare. But what, as I said, we would request the federal government to give our state the same amount of money that they've already pay to people that are on Medicare, and also what they give us for Medicaid.
So I would pay my bill to Ohio then instead of Medicare.
Well, your taxes would go to Ohio, yes.
Well, right now Medicare is charging me what, $150 a month.
Right. And you would
so I would not be paying that?
No,
I'd be paying taxes instead.
You'd be paying taxes instead. Just like we already do pay taxes for Medicare. It's just that Medicare doesn't cover anybody unless you're 65 and over, and a few other things.
Thank you.
Giovanni, when you ask your question, I've got a question for you too. How are things in Canada, Mr. Canadian citizen?
Well, I was going to make the point. You got somebody that lives the single payer here. And I lived in 3 countries, actually. Obviously, my country of birth, Italy. And I lived in Cuba for quite a bit. I used to be married to a Cuban. In Cuba, actually, a nurse comes to your household to check everybody's health care, measures the blood pressure, all that stuff. Anyway, but going to the political realm, of course, the question is paraphrasing a famous politician, what's to be done? Now, we have all 3, the president, the House, and the Senate, all 3 in the hands of the Democratic Party. And where is universal health care? Where is your call test? What's her name? OSC. Where is Bernie Sanders? Why are you discussing nickel and dimes over here? Like, where are they? Biden said it's not going to happen. If he comes to my desk, I'm going to veto it. He won't. He said, he won't come to my desk. But if he comes, I'm going to veto it. So paraphrasing that famous man of the late 19th century, what's to be done?
All right. What's to be done, Jeanne?
Continue to educate people so they understand. We've got to get rid of the fear.
There is the statistic respect. Even the electorate are in favor of it. It's not a matter of people. The majority of Americans support it. Every poll.
Yeah, Giovanni's breaking up a lot there, but he's saying, "What are we waiting for? America, the majority wants it." Jeanne, what's holding Biden up?
Well, it was never on his agenda, to be honest. He was never a proponent of universal single-payer health care. He's not. He's never. This is not part of his agenda, and it's not going to happen, probably under his guidance. But
so are we waiting? Are we waiting another Trump in 2 years? In 4 years?
Deep question. Let's move on to Bill's question. William Messer. Bill has a question.
Well, it's not so much a question as a follow-up to this. Biden is deeply invested in whatever Obama did. So he's a strong supporter of the Affordable Care Act, and he wants to tweak that, but he doesn't want to leave that. So I think, to answer Giovanni's question, the best thing we could do is to get Obama to say, what I really wanted was universal health care, but we couldn't do it.
Yeah, Hillary Clinton too.
Actually could, Bill. This Obama got Obama. Now, by the way, he's living on a $17 mansion in Martha's Vineyard, and I don't think he's thinking about your health care at all. But he had 2 years. He controlled both House, Senate, and the presidency. And he canceled the public option. Remember that one?
Yeah. But
and the affordable health care is not the affordable. Everybody's saying is the two presenters, the doctor and Dee, say affordable. It's not affordable at all. So
let's not rehash. It's
still a private system, and that is the problem.
Did Obama move the ball forward?
Yes.
Yes.
Absolutely.
No, he didn't. We can discuss the numbers. Doctor
Medicaid expansion
told us the numbers. This is after Obamacare.
Yeah.
That's nothing to tweak.
Medicaid expansion was the biggest reason why we had such a drop in the number of uninsured in the United States, and that was part of the Affordable Care Act.
Yeah.
We expanded.
Well,
yeah. That's good.
Still,
we got a
it's not.
We got a yeah out of Giovanni. That's great.
No. Sì, signore, sì.
No.
You said sì.
The Obamacare, it's a further privatization of a private system. It gave the insurance company 30 million customers with
Giovanni,
are you guys serious?
God is intervening, Giovanni. He's breaking up your voice. Somebody doesn't want us to hear what you're saying. No, I'm sorry. I'm sorry that you're broken up so much, and we can't hear you.
So I did have a question.
But let's go with Bill Messer here for a second.
Okay. So when Jeanne and Dee, I couldn't remember both names.
Jeanne and Dee, yeah.
Like
Jan and Dean.
Yeah, I knew.
Surf City, here we come.
So one of the things you said is there would be no advertising. So I assume that means that the drug companies that like to tell us about their newest drug won't be telling us about their newest drug, and we won't have the opportunity to say to our doctors, that's the drug I would like.
Ooh, good one, Bill. I mean, let me just interrupt before you answer. I'm from the advertising industry, and for the longest time, lawyers and doctors and pharmacists and medical people, it was below their dignity to advertise, and that got busted open. The idea to me is putrid, that people who make medicines are able to push in your face, use my medicine. I understand the freedom of speech in it, Bill. I understand that part of it, but yeah, let's talk about the freedom of pharmaceuticals to push the drugs on you, where believer in the doctors who have saved my life 3 times, let them decide what I need as opposed to what some slick advertising agency says I need, right, John?
I'm not talking about something like pushing drugs, although
that's what they do.
That's what an advertisement is.
You could call them pushers, yeah. But,
yeah.
I'm just saying, generally speaking, in a capitalist society, that's how manufacturers make the public aware of their products.
Yes.
So address that, please.
Address that, Jeanne, please.
Doctor, get on that one, doctor.
The capitalist society has failed healthcare.
Yes, I agree.
You don't know what it's not like you have all these products and you know exactly what you're going to get and how much it costs, and you can make a decision. Healthcare doesn't work that way. we have a capitalist society running our healthcare now, and it's been a failure. So it doesn't work with healthcare. Now, you can, keep up with the FDA and see what drugs are approved and do your own research. The information is not hidden, what new drugs come out, but to advertise them is to push them. The pharmaceutical companies, big pharma, 35% of their budget, 35% is spent on marketing. They are drug pushers. So 13% goes to research and development.
Yeah, I was reading the book. I told you I was reading the book Your Body. I forget the author's name, and I heard a doctor, my urologist said, I can give you more testosterone, and you'll be, and I'm going, okay, yeah, I'll consider that. After I get my COVID and I know I'm going to live, maybe I'll consider that. But now I'm reading how testosterone reduces the lifespan of males. And I'm going, the drug company that's going to push me to use testosterone to have, a more vigorous life is not considering the fact that it may shorten my life. They want to sell the drug. Somebody has to come in who balances all that out. Am I right or not, Jeanne?
Right. They're just promoting a product that may or may not be of benefit to you for their own financial gain. And yeah, there are people who may benefit from that product, but they're pushing drugs, or you're learning about drugs that are not generic. Let's start with that. Nobody advertises generic drugs. So, anything that's being advertised is, relatively speaking, a high cost drug. Sometimes it's just a tweak of something we already have that's generic. The pharmaceutical company can do minimal research and develop, modify it in just a minor way, and promote it as newer, bigger, better. And you're going to see a commercial for it on TV when there may be a drug that is almost identical that you can get at a generic cost. So advertising pharmaceuticals is a cost problem. And if we want to bring down the cost of healthcare, advertising should not be allowed.
You touched.
What do you think, John? Let's have John have a say. John's an advertiser and a marketer.
Well, there you go. But my thing is, and Jeanne, you're a doctor. It's the direct marketing and how powerful the drug companies are. And is that also part of the marketing budget that was eliminated?
Yeah, the trips they give doctors, trips to Italy where see Giovanni, if they push this drug. Yeah.
Well, Jeanne.
So, yeah, there have been more and more regulation, not in a bad way, for pharmaceutical and what they can do with physicians. I've been in medicine a long time. I missed all the vacations. There were never any vacations offered when I've been a doctor. In fact, the only, if they pay for your dinner, it has to be an educational program. You have to sign in. It's fairly tightly regulated. They get around it in some ways, but it certainly is better than it was in the old days. A number of offices, not all, but some offices do not allow the pharmaceutical reps to come in and speak to the physicians. And I, as a physician, about 10 years ago said, I've had enough. Our office would allow them to come in, but I personally stopped talking to them. I was done. I was done. So, they would try and, again, sell a product. There was a birth control pill called low estrogen. Well, then they had low estrogen, just a tiny tweak. And it was new, improved, not generic, expensive. And that's one of the ways they keep their drug prices high, with minimal research and development. So, and there are countless examples of this. Yes. So, it is fairly regulated.
And they pushed so hard. As a nurse, I was many times, I never got an invitation for a trip to the Caribbean or anything, but I was given many invitations for steak dinners and so on to go out and, hear a program that the doctors were going to hear. And they would say, we want you to tell these doctors that you work with about this new drug or this, the benefits. They push it really hard. I can't prescribe medicine, but they were pushing me
to tell the doc.
Yeah.
Brian Lenahan has a question.
Okay, it's actually a statement. One problem with Obamacare is that not enough people wanted to sign up for it. It's hard to get younger people to sign up for it, possibly because they didn't think they needed health insurance. They didn't have any health problems. And I think a couple of years ago, they removed the penalty for not having health insurance. I think a penalty is about $150. I think maybe a lot of people are against the Obamacare or National Health Care Plan because they don't want to pay for someone else's health care, or they don't think they need it themselves. I can think of one example. There's some group I was in, and it's an alumni group, and on the Facebook page, someone had GoFundMe it was someone who was involved in some accident. He had high medical expenses, and he didn't have health insurance. And that was at a time when he could have gotten Obamacare. And I go through that. I never met this person. I didn't know him, but I went on his Facebook page, and maybe I'm probably judging it. I could be totally wrong, but by his Facebook page, it looked like he probably supported Donald Trump, and he's probably against the Affordable Care Act. But then he was in an accident and position he couldn't pay for his medical bills, and he didn't have health insurance. So I think a lot of people don't think it's not going to happen to them, and that's one reason people don't get insurance even if it's available.
Yeah, the docs will tell you that kids in their 18 to 20s, and their brains are different, and they are open to greater risks, and it's a different kind of brain. It's not fully developed until the mid-20s, right? I'm guessing just from what I've read. Bill, I'm sorry, Brian has a question. The other Brian, Corwin.
Yeah, I'm right in there, so I guess my brain's just about done developing.
Congratulations, man. Welcome aboard. The rest is all downhill.
Oh, yeah. All right, so I have a question. I'll be kind of playing devil's advocate a little bit here. So
sure. Absolutely.
So I'm with a bunch of professionals in training, and of course, we talk a lot about advocating for our own profession. And in some cases, that means advocating for our incomes and our work as an employee. So I know that this is a topic that comes up a lot when I discuss single-payer systems with people. People are concerned about healthcare workers taking a hit to their income. So I wanted to ask, particularly since we've been talking about single-payer systems that are publicly funded but privately owned, does this significantly change reimbursement for services as compared with private insurance? Would it be less, more, the same? And how could this impact the income of healthcare workers?
Yes, so I can comment on that. So being a doctor, I would not have included this information because, the talk is for different groups. But if you look at the income of physicians in Canada as compared to the United States, they're pretty darn close. And again, that's our best example. They're pretty close. Keep in mind too, so we have the bills, the House bill and the Senate bill for the national universal single payer. There is no payment fee in that. It hasn't been decided. There's a lot of unanswered questions, but you have to have a system that functions, and you have to pay not just physicians, but nurses and all the ancillary services. You have to pay people fair wages. So it would be detrimental to the entire system to pay so little that you would have a mass exodus. It doesn't make any sense. The whole system would collapse. And again, most countries or all economically advanced countries have some sort of universal system. And if we look to Canada, the physicians' incomes are similar. It's probably estimated that some of the really high paid super specialists, maybe like the neurosurgeons, might take a hit, but might come down somewhat, but hopefully not in a significant, they did not have an exodus in Canada when they went to the system. The doctors revolted for a few months and then they came back and it's been fine. And it's been a number of decades now.
There was it's a foggy memory, but there was a revolt in Ohio, wasn't there, of lower payment and we lost doctors.
I think it was when malpractice rates.
No, you know what? I shouldn't have spoke up, but
Okay,
it's such a foggy memory. I'm not going to bring it up. Michelle has a question.
Yeah.
I'm also wondering about cost. You said it would cost 5%. Is that adjusted 5% of adjusted gross or 5% of wages? 5% of what?
Oh, you mean the tax?
Yeah.
The 3 to 5% tax. It's adjusted gross.
So that would be a severe penalty on people who have saved their money their whole lives and are forced into required minimum distributions that would push their income artificially high as they get disbursements. Because I just calculated that the 5%, if I took 5% off using the premium I pay now for Medicare, which I think is high, $145 a month is high to me. But if that would be 5% of $34,800. So 5% of a higher number obviously would be a higher premium or higher expense.
I'm not sure I'm following how you're figuring that out, but you have.
Well, if I take $145 a month and I multiply by 12, and then I divide that by 5%, then I find out what the principal was that generated that 5%, and that's $34,800, which really isn't a very high number. So that I would be concerned about people who saved money their whole lives, and this is a thing, you know. They have the required minimum distributions that makes their income look artificially high because they're forced to, take those disbursements.
I'm not understanding either, Michelle.
I really don't understand.
I don't know enough about that.
Well, the required minimum distribution could make your adjusted gross look high. Okay, because you're forced to take the money out of the tax advantage account and bring it into your taxable, and then your tax dollars. Okay, so it makes your adjusted.
Well, I'd really be surprised if you're like right now, if you say you're on Medicare, if you pay 140 or 45, I think it is,
yes,
a month. Is that cannot be your only healthcare expense. I mean, first of all, if you have a supplemental, you're paying a premium for that.
No, I don't pay anything for that. I have Medicare Advantage, and that's all I pay.
Okay. Well, if you have Medicare Advantage and you go to the doctor, you're going to most likely pay a copay.
$5.
Okay, and you're probably going to be paying some upfront money if you get sick. Now, you may not pay anything, just do checkups and if you stay healthy. And I don't know what you do about medications and so on. But if you get sick or if you get hit by a car, you're going to have some big bills. And that's when Medicare Advantage will get you. They will bill you out the wazoo.
There's a saying about Medicare Advantage: the healthy go in and the sick come out, because their networks are so narrow and their formularies are so narrow, and that's how they are able to artificially keep healthy people in. And they do run an overhead percent, by the way, of 9% to administer it, and that's our tax dollars paying for that. So it's a problem running Medicare through the private companies in the form of Medicare Advantage, because it overall costs more. And again, they have a lot of bells and whistles, but if you really need it, you'll be surprised at too many people are surprised at what they end up unfortunately not covering, because it's a fairly restricted policy.
I question that and I have friends who have pretty serious health issues that I wouldn't wish on anybody. And they said the Medicare Advantage
Michelle, your audio stopped.
It's an anecdote, but
Yeah.
Keep in mind that Medicare Advantage, like any private insurance that's not Medicare Advantage, there are multiple policies, and what they cover is going to vary from policy to policy. So I only speak in generalizations, but each policy is going to have differences. And there's one example that a patient had that was diagnosed with hepatitis C. They were on Medicare Advantage. We all know that the medication for hepatitis C is very, very expensive. Well, lo and behold, it wasn't on their Medicare Advantage formulary. So that person then switched to traditional Medicare. So that's just one example of how people are surprised when they have a significant health need that their policy doesn't always cover it. And then that Medicare Advantage policy, that patient who was a high need, high cost patient has left the policy. So you just have to be careful. But each policy is going to be somewhat different.
Isn't it amazing? We have to all jump through these different kinds of hoops in order to get what we need. What any enlightened country should say is, yes, take care of our people. Yes, educate our brightest. Yes, you know, and there's so much money in the system with people making $10,000 an hour who happen to make what, 2 or 3 million a year. The money, yeah, it's there. Let's just.
We're already spending it.
Yes.
Keep in mind, we're already spending more on healthcare per person than other economically similar countries, twice as much.
And I'm not an economics major by any means, but I learned in economics. I fell asleep in most classes, but there's this idea of elasticity, and we talk about, can we, you know, if I want a pair of Gucci shoes, I can say no, that's too expensive. But if my baby is sick, I have to pay it. There's no elasticity. There's no yes or no in there. There's no do I want it or not. So the supplier can charge anything. And it's okay. Brandy has a question.
Randy?
Did I say Randy or Brett?
Well, you kind of combined us.
Yes. You guys are combined as a group here, yeah.
Yeah, just going back to the rather devious ways insurance companies can control who gets their product. I mean, they not only, pick the cherry pick, but they have ways of, for example, of filtering out people who are very high cost. I mean, somebody with cystic fibrosis, all they need to do is not renew the contract for a cystic fibrosis specialist. And that person, it makes no financial sense for them to stay with that insurance company. Mm-hmm. It doesn't look evil, but it has the intent of what they wanted to do. I mean, that's just one of many things.
And choice is taken out of the equation. You don't have a choice.
And
so
another problem with a public option is like one of our guests here said that that's really not a solution, and it's not, because it still leaves the government with the most expensive subgroup of patients, and the insurance companies get again to cherry pick and keep the profitable ones and make them look very good. Just, logically, if you put everyone in one huge pool, the per capita cost of insuring them goes down.
Yes.
That's a message that the Democrats need to start clarifying. Put it in simple terms. Mm-hmm. This isn't inherently a dumb public. It's just terribly uninformed.
Uninformed.
The Democrats often are paid by these same corporations and influencers as the Republicans. It's just that there are more thinking Democrats out there. I
hope so.
I hate to be political, but let's be real.
Politics is everything. It's everywhere. Bill.
Yeah, as long as you're talking about politics, if you're scaring a lot of people off because they think it's socialized medicine or it's a socialized method of paying for medicine, I was thinking we might be able to get a very large group of people by informing them that the National Socialists also had universal health care, And we could get all the Nazis to vote for it as well.
No, 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 no.
All
The
right,
better
so-
way, the better way is to say how many things are socialistic in your life. The fire department, the police department, the library, the U.S. military, which can do anything. It has its own manufacturing, its own distribution, its own education, and it's a government job. The government can do great things if you let them.
Way too rational for a lot of people. But I had a couple, and by the way, Michelle, I'm paying $700 a month for Medicare.
Ah.
And that's because most of my working life, I lived in England, and the US did not have a reciprocal treaty with the UK. And so all the work I did there and all the money I paid in there for healthcare in the UK does not apply over here. And we have penalties if you don't get Medicare when you turn 65. And so for 5 months, 5 years, I had a different kind of insurance. And now I'm having to pay all those penalties for not having, it's mandatory. You have to get Medicare. So, you know, so anyway, it's insane what I'm having to pay, you know, in case I have a heart attack or something. 2 questions. One of them is, speaking of England, in England, they have socialized medicine, but they also have private doctors. They have the Harley Street physicians and stuff. Are you talking about the possibility that there would still be some private doctors? Question 1. And question 2, and this is something medical, big pharma and small pharma maybe often talk about, is how would this affect R&D? Because they like to claim that under this system,
Good
they
question.
have a large pot of money for R&D. Where does the R&D money come from?
And they do great things with that R&D, by the way.
Yeah. Can I start with the R&D? Because that's a little more straightforward. Keep in mind when we look at, I'm looking at my notes, you know, I'm old and I can't remember things, but the drug company costs, they're 35% marketing and advertising. So the research and development is only 13% of their total budget.
Does that vary from company to company, or is that just generally? That's an average.
The big pharma.
Big pharma.
Okay. Conglomerate. So it's 13. I'm sure there is some variation from company to company. So they're not really spending a lot of their money on research and development. So also keep in mind that a lot of basic research is done, it's funded by the NIH. You know, it's government funded at the university level. A lot of the original bench researches and pharmaceutical researches, and sometimes then the pharmaceutical companies will pick them up a little bit later on. So there probably would be some change, but again, the companies could do much better by using some of their income for research. They're not using that much for research and development now.
Can I assume that 13% is still a whole lot of money?
Oh, I'm sure it is.
Oh, yeah.
A whole lot of money. Yeah.
You could have a whole lot more. We have a question from Brett.
Wait, she's got a set.
I'm sorry. I'm sorry.
A whole lot of money. There are pharmaceutical companies that are quite successful in countries with public health insurance, where they have price controls and they can negotiate price. They're successful pharmaceutical companies.
Yeah.
They just might not be quite as flush with cash.
Merck.
Pfizer's vaccine was developed by BioNTech, a German company started by 2 Turkish immigrants to Germany. And Pfizer contributed a little bit of financing, but here we know it as Pfizer. Well, we're not the only ones, you know, who
in
are
the world, right?
And Oxford AstraZeneca was developed at Oxford University, I think. Yeah. And so what was the other question? Private doctors.
Oh, so I don't really know because I'm not sure. I do know that you can't have insurance. Like if it's the way the bill is written, you cannot purchase duplicative insurance if it's covered. You can only buy insurance that isn't covered under the national plan. So, because our proposal is for the, you know, publicly financed but privately delivered like Canada, and I don't know how that compares to the English the British system, which is a truly socialized. So I can't completely answer that. I don't know if you know, Dee. But you don't want a two-tier system overall, because that causes problems. It's the haves and the have-nots is what ends up. So we all need to be in this together to make it work. We all need to be invested in the system.
I agree.
There's a question in the text in the chat here by Brett and Randy. Would there be medical professionals in charge of oversight of the system, or would it be dominated by Wall Street types and their politicians? Who controls this oversight?
Well, okay, in the bills that are very similar, there are going to be it's going to be regional centers for administration, and it would be made up of a panel of people. There would be healthcare professionals, community leaders, advocates, probably politicians, probably a mix of people with economists. But it doesn't specifically say 3 of this type of people, 3 of this, 3 of that. There are a lot of unanswered questions like that.
Who do we want it in charge of? Who do we want in charge?
A mix of people.
I'm sorry?
A mix of people.
A mix? You want a mix? Okay.
Absolutely.
Yeah. From the doctors I've met, I want my doctor in charge, but and not a insurance, but okay. Brian says, I was at a lecture where the speaker said pharmaceuticals represents 10% of healthcare costs. The speaker was a CEO of Eli Lilly. Is he lying, or is he right on?
Let's see.
10%. I don't know what it means at 10. Brian, explain. What does it mean that a pharmaceuticals is or are 10% of healthcare costs?
Well, the cost of medicine.
Cost of medicine.
Cost of medicines. Cost of pharmaceuticals.
It's 10% of our costs.
Yes.
I don't know.
I'm not sure.
We don't have the answer to that.
I don't have the answer.
Oh, folks, what a great enlightening, stimulating conversation. Brian Corwin has a question. You're muted, Brian. Okay.
Yes, I got one more. Hold on, let me read it again. So yeah, here's kind of another devil's advocate question that I want to try to get answered. So, and this could be regarding the Ohio Healthcare Act, or like what Medicare for all would look like nationally. But could the current healthcare systems in place, the hospitals, outpatient clinics, and so on, handle the increase in patient and clientele without needing to expand, or would we need to hire and train more healthcare workers, create new opportunities, and so on?
Well, are you asking on the state level, or I guess Jeanne could answer this?
Or whatever you guys are not prepared to answer.
Well, right now, people who are uninsured tend to end up in the ER when they get sick. So they're requiring much more complex care. And, if you can go see your doctor every year or every 6 months or whatever and get preventive care and get, take care of things as they come up, you're not going to get that. Well, you could still get that sick, but it's not as likely. I do want to tell you a statistic, and this is an answer to something you said too, Giovanni. Obamacare did help a lot because of the expansion of Medicaid in several states. And this is answering your question too, Brian. When they did a study after the expansion of Medicaid in Ohio, I think it was 2 years after, and they found that there was a very significant reduction in ER visits, something like 17%. There was also a significant reduction of other things like cigarette smoking. 30% of people were able to stop smoking. And you would think that, if you're a smoker, it doesn't matter whether you have health care or not. If you quit, you do it on your own. But that's not really true. You can get help with that. And you can discuss that with your healthcare professional and find out what it's doing to you. Like you're likely to get lung cancer or heart disease. and you're more motivated to stop. So, I mean, anyway, that was a significant part of the ACA, that it increased Medicaid. Something like 30% in Ohio, 30% more people went on Medicaid. And so can't remember how I was relating that to what you said, Brian. Oh, you're worried about not having enough healthcare professionals. Let's see. I think that the only thing I know is that there would be less catastrophic care. I remember reading something about that. Jeannie, do you remember?
Yeah, it's actually been studied on a national level. Like it's been looked at in Canada when they introduced their system, and here with the Medicaid expansion, there's a small blip at the beginning, and then it tends to even out in utilization. So at least the data so far has shown that when we've had these large increases in people with ability to access care, that the system has been able to accommodate that. Now, of course, any system has to change with time. So overall, you know, you have to, and we have a problem with, we do not have enough primary care physicians in the United States, but that's a whole different problem.
Yeah.
Yeah, part of that was AMA's policy of keeping the what's the supply and demand at a certain ratio. I think it would be very beneficial for the government to promote education, educating more nurses and physicians and other providers, social workers, and that would only take, I mean, a short number of years before that would catch up. But
right.
Brian Linehan has another question.
Well, maybe I think one way to have more doctors and health professionals is to make medical school free. Well, you still have to qualify to get in. They wouldn't take anybody. You have to meet the qualifications.
What are you, a communist?
Yes.
Well, I think one problem with
are you serious?
From each according to his need.
One problem a lot of doctors have when they get out of medical schools, student loan debts. I know, but but if you make medical school free, then finances wouldn't be a barrier to go to medical school.
Why wouldn't a country that wants to succeed and do well and take care of its people, why wouldn't they educate those for free, those who are capable of taking the education and doing something?
Okay, who's got the answer for that?
What is it?
No, I don't know. Who's got the answer for that?
Who's got the answer?
I'll give you one.
John Nagy.
I can come up with mine, but it will be too long and involved.
John Nagy has an answer to that.
Well, I have a nephew who is a physician, and his way was paid free through the military.
There you go. And
he's doing all right.
He's doing all right. We did it all right. All right.
Yeah. So you give a little service to the country, and they take care of you.
Government by the people, of the people, and for the people. Why not, excuse me, fucking educate the people?
Well,
all right, and feed them and take care of their health.
An educated public is a very dangerous thing.
And good danger. It's what they call, what's his name called? Good trouble. John Lewis called good trouble. We educated, we got good trouble. They want us uneducated as, never mind.
I'm wondering if there's people who haven't said anything yet who are thinking questions.
Yes, let's hear from the quiet ones. Sonia, Mike. Giovanni has been shooting his mouth off all night long. We don't need to hear any more.
Well, I can still answering all those complexities by Michelle with the tax and all. Come to Canada, it's very simple. I pay my income tax. I don't have to calculate anything.
Yes.
If I made little, I pay little.
But you're
if
saying
I made a lot,
you're having trouble getting your COVID shots.
No, well, that's another issue, but we're gonna get it. we're gonna get it, and it's But you know, the guy that paid no income tax last year because they didn't make enough gets the same health care that the guy that paid a lot because made a lot of money.
That's right.
He gets exactly the same health care.
Because we couldn't run this system, we couldn't run this country, we couldn't run either country without everybody's cooperation. So everybody's in. Okay,
I think the reason Giovanni doesn't have his shots yet is we would take him up on his offer to come to Canada as soon as he's vaccinated.
No, actually, the problem is
your place.
the problem is that our prime minister made a deal. He bought them. He bought the vaccines.
Yeah.
But Pfizer, they didn't deliver. So much for the market. The market. What do you call it? The magic hand. What was the Adam Smith?
Invisible hand. The invisible
hand.
Yeah.
So the invisible hand didn't show up in Canada.
I'm working on an essay called "The Invisible Hand Job." It's not a good deal. It's
I knew you were going to go there. I knew you were going to go.
It is not. The invisible hand is.
It's really in Canada.
It's like
trickle down.
It's like trickle down. Yeah, it's trickle down. It's a fake. It's a trick. It's never mind. I'm sorry.
If it's trickle down, you're not doing it right. If it's trickle down, you're not doing it right.
I'm sorry if I overstepped the bounds there.
You better stop now. You're just digging
okay, I'm done.
A hole for yourself.
I'm done.
Well, if I can jump in for a minute, I just like to say again, this topic has been near and dear to my heart for many, many years. I can't thank both of you enough for what you're doing, not just being here with us tonight, but on an ongoing basis and trying to change the way things are set up in this country for healthcare. It's I think a travesty. So thank you very much for being here.
To Jeanne
tonight.
and Dee. Gracias.
Join us. Look at the websites, both websites, and you can join for very low cost and you can be part of the fight.
I will put the website links in our report. If you are not signed up and you do not get stuff from us every month, go to the homepage of gofigure.org and say, send me your crap, and I'll send it to you every month. And that's about it.
Thanks for having us.
Thank you.
My
one
pleasure.
Other thought. If
Go ahead. One other
Thank you,
thought.
Dr.
Thank
you, Dr. Corwin.
Oh, hang on. Wait a minute.
Sonia, let Sonia speak.
Yeah, she hasn't said a word all
If
evening.
pharmaceutical companies were no longer advertising, we might just have such a big vacuum. It might create a black hole. With the pretty little pens and the notepads and the clipboards and all those TV commercials, what would we do with ourselves? We might actually have to think about something.
Always keep them laughing when you say goodbye. Nice job, Sonia. Beautiful.
Right. We'd all be sucked into that black hole, wouldn't we?
Maybe.
It might be wonderful.
I was going to say, I can hardly wait.
Okay, all the best to you guys. Get your vaccinations, and
thanks, everybody.
We'll see you time. Adios, amigos.
Thank
you. Thanks,
Thank
Peter.
My pleasure. Wonderful, wonderful. Good evening. Thank you.
Yeah, very good.